Thanks for the invitation to speak here. I'm going to jump right into my talk. So I have disclosures to declare. None of these affect what I'm going to say here at the conference. I'm coming from the University of Idaho. My training is as a mechanical engineer, so I definitely have a different perspective than a neurosurgeon on this disorder. I kind of want to share with you that perspective. Hopefully kind of learn along the way together about ideas, how we can look at Chiari and quantify the disease states. My lab at the University of Idaho is shown here. We have 4 arms: neurological disorders, medical devices, astronaut, eye biomechanics, CNS therapeutics. I'm going to talk today about Chiari malformation. And actually I have a student here with me, a PhD student in the back, who's doing the research on this. She's just getting started, so if you have tough questions, she's ready to go. She can answer anything already. Okay, so I think one of the real problems in Chiari malformation is that, as Dr. Vez just stated, many people in the general population have incidental finding of Chiari. They don't have symptoms. There are several studies that sort of highlighted that. There's a large study by Smith et al. That showed about 1%, 2%, 3% of the adult male, female, and pediatric population have incidental finding of, quote, Chiari. So this represents a pretty big problem, right? We need a better biomarker for Chiari malformation. However, Spear et al. Did a study earlier that showed only about 0.6% or 0.06% of the population actually have symptomatic Chiari, right? So there's a big disparity. It means only about 1 in 30 people that have the anatomic sort of malformation actually have what you would consider Chiari in terms of the symptomatology. So I want to share with you sort of my perspective on why that is, and obviously this is really simplified in the sense of what the way an engineer would think about this. So at the end of the day, we sort of look at Chiari as this 1D measurement. You can see here on the left side, this is sagittal MRI. But in reality, it's really like a 3D complex shape of this tonsil and the whole cranial vertebral junction. Here's a coronal scan. You can see the left and right tonsil. And then axial scan, you can see sort of the tightness near this cranial vertebral junction. So if we look into that more detail, this is showing the cranial base bones here, the basion, opistheon. And normally these are the reference points for which you make this measurement of tonsillar position. Now, I think any of us can see here, they're curvy bones. You have the occipital condyles that protrude at the base of the skull. You have this arch, the basion and opistheon. So when you're making this measurement, it's like you're making it with reference to all these curvy bones, and those obviously you can see here, if this projects more upwards, just locally here, it can make it sort of seem like you have more tonsillar descent, right? If this just has a bigger arch. So relatively speaking, the tonsils might be not really protruding out of the skull per se as much, right? So you can see this is a geometric kind of question. How do we do this, right? We're simplifying it. We need to simplify for radiology, practically speaking, because a radiologist has to make a useful measurement, right? So this is sort of what we're dealing with. Okay, so we talked earlier, in reality, one piece of the problem is sort of how constricted the space is near the cranial vertebral junction. And this is a complex space. This is a model that we built in my lab. This is the full CSF system around the brain and within the brain. And well, this is the cranial vertebral junction. You can see here, there's a lot of complex sort of fluid space there that really, in reality, we'd like to look at all of that whole space, right? Okay, so if we think about this a little bit more, it's also not just a static problem, right? We have Chiari, it's not just one little measurement. In this person here, so this is actually a Chiari pediatric patient, and what you'd see in the video is, well, what you'd see is sort of the tonsils pulsing with each heartbeat, right? This is a dynamic problem. If you don't take into account the motion of the tonsil at all and the way you're looking at this, then you're kind of missing a piece of the picture, right? Okay, so even further, we know the tissue is moving, but also the fluid around the tissue. So this is a computational fluid dynamics model we did of a Chiari patient. Actually, I don't know how to go back. There you go. It's a Chiari patient. And essentially what you see is the fluid pulsing back and forth in that space. And you can see it's a complicated arrangement of how the fluid pulses with each heartbeat, right? So you have solid movement, fluid movement, then you got the anatomy, which is all complex. Okay, so from an engineering perspective, we kind of think about how can we split this into a tractable problem and think about each piece of the pie, okay? So here's my pieces of the pie. We have static measurements on the left side here, these three types, morphometrics, CNS tissue properties, and then we have dynamic measurements. These are CSF hydrodynamics and then tissue deformation. We can look at this with different imaging tools, which I'm going to talk about in this talk. We can also think about analysis techniques and then have findings. So what I'm going to do is step through in this talk each category. So the first one here is neural anatomy morphometrics. And what I want to do is give you a very short snippet about some findings in these areas. They're not comprehensive. There's a lot of work going on right now, really great findings in each category. I'm going to just highlight some pieces that I think are interesting. So neural anatomy morphometrics. We did a study using machine learning, and what we did is we measured 15 different features in the brain. You can see the 15 features here. This is not comprehensive. This is sort of typical measurements that have been performed in Chiari malformation. We applied machine learning to those measurements, and we tried to use machine learning to see if can we categorize people with Chiari malformation symptomatic without even measuring the tonsillar position at all. And it turned out we could. We found 90% sensitivity specificity using this simple equation here. So it's basically prediction equals this number minus this number times distance fastigium to foramen magnum, this number times this number times that. So actually, if you all had your MRI images, potentially you could make some of these measurements. This is not a final value. This is just saying that it is possible to quantify with quite high level specificity, sensitivity, Chiari without measuring tonsillar position, right? So that gives a little interesting indicator there. Okay, so one thing we learned from this study was that these measurements are challenging to do. We wanted to give some numbers for how challenging are they in terms of their reproducibility, reliability, right? So we're going to check out reliability. Okay, so we did another study where essentially what we did is we had 7 operators measure 33 MRI data sets. So this is 33 different people. It was a range of tonsillar positions. These were all sort of what we consider high-resolution MRI, better than standard that we usually get for Chiari patients. And we actually had a very interesting result. What we found was the range for any particular person of that measurement was 8 millimeters. I think everybody here in the audience can say, holy cow, that's a pretty serious problem. If your diagnostic threshold is 5, but the measurement range is 8, it's a problem. The standard deviation of that measurement was 2.54. Now, remember this number, 2.54, standard deviation. Anybody do statistics here? Yeah, a little bit? Okay, so statisticians, remember this number. I have a quiz. Okay, so here's the measurements. These are the standard deviations across all the different MRI scans. You can see these black bars as standard deviation. You can see that the tonsillar position variation is big for every subject. And these are trained expert operators. So these are people who are familiar with measuring Chiari. Okay, so then we said, well, hold on. We better look at all the measurements that have been done in the brain. So here is the tonsillar descent measurement. Here's basilar impression measurement. And then here's a whole bunch of other ones. This is actually 20 measurements. We did this with 6 different operators and then checked how reliable is it across all 6. Well, we saw something very interesting. Tonsillar descent and basilar impression had the largest coefficient of variation of any measurement. Not good, right? This means the measurements that we are using most commonly to help diagnose Chiari radiographically, right? The symptoms, as Dr. Vez said, are really important. That's the first thing that are looked at, right? It's very unreliable, right? Okay, so I want to zoom out in context of the literature. Kind of interesting finding here. Remember, I said Smith et al. Had a study where they said 1, 2, and 3% of the general population has incidental finding of Chiari, okay? So let's zoom in on this. So this is their findings, 0 to 10 years, 11 to 20 years, 21 to 30 years. They actually did it across the whole population. It was in over 2,400 people. So this is a huge study, totally awesome work. When I saw this paper, I was like, wow, wonderful study. Does anybody see a problem? Anybody see a problem in this figure? This is healthy people. So look, hopefully, this is the problem. Healthy people have tonsillar position below the foramen magnum greater than 5 millimeters in all age groups. It's not a lot of them, but it's quite a few, right? So this is the diagnostic problem of Chiari right here, right? This is saying these are healthy people, no symptoms. What's going on, right? Okay, so think about this. In an engineering sense, so this is my only equation in the whole talk, okay? Promise you. We have a normal distribution function, okay? There's a standard deviation and the function center. So remember that standard deviation I said before, 2.54, right? This means the variance of the measurement for expert operators, right? Here's our plot of the measurement in the population, the average measurement in population. If you actually take this function and you put in your sigma value and you plot it across X, you'll see that it's exactly on the histogram. So it could be that the Smith et al. Study didn't really plot the true variation in the population, but more the variation of the measurement reliability. You see that? Kind of interesting, and I've talked with the group about this. It's a different perspective on their study, but nevertheless, you can see this, right? There's variance in the measurement. This might just be because the measurement isn't very precise, right? Okay, so that's neural anatomy, morphometrics. So now I'm going to switch and talk about tissue properties. I think the take-home point here is that we can measure Chiari, we can identify it with other measurements beyond just tonsillar position, and really we need to look at that in more detail. There's a bunch of great papers coming out of the University of Akron group looking at morphometrics even recently, and those are things that are definitely helping lead the way in that area. So really quickly here, CNS tissue properties, there are some findings that show these can be altered in Chiari. One way to look at these properties is something called diffusion tensor imaging. Essentially what that is it looks at how water flows in the brain. And you can imagine water flows more along axons than transversely across them. So I'm going to graze through this really quickly. There was a study in which they applied this in Chiari malformation looking at fractional anisotropy. This is actually how water moves along axons versus transversely across them. And they did find that these were altered in Chiari malformation patients and that these values normalized after decompression and that they did not normalize for people who had Syringomyelia before that surgery. So this is a very limited study by the Hodai group, and it needs to be checked out more, but you can see here maybe there's some microstructural changes that coincide with the anatomy, right? So this could be another indicator of what's going on in Chiari. So I think a take home here is that there's enough evidence to say that there's probably changes there. It needs to be looked at in more detail to figure out precisely what region is the best to look at and what type of sequence to use and so forth. So there's a lot of research that needs to be done to really understand, is this useful for Chiari and how to do it best. So the next part here is CSF hydrodynamics. Dr. Vez kind of mentioned that. So there's a lot of sort of different findings in CSF hydrodynamics in Chiari. And I think what we wanted to do was just start to look at them on average. So we did a meta-analysis of every study in CSF hydrodynamics in Chiari. This represents assessment of over 96 patients and 176 healthy controls. And what you can see is, on average, the CSF peak velocities at the cranial vertebral junction are elevated in Chiari. So Chiari is the light blue and healthy is the dark blue. You can see they're elevated on average across all these studies. And the biggest region that is affected is the C1 vertebral level. So if you're going to look to try and quantify these changes, you probably want to look at C1 because it's the biggest difference on average. However, I want to describe some of the challenges with that measurement as well. So when you look at CSF flow at the foramen magnum, this is a special sequence which doctors generally do not do. It's called 4D flow imaging. What it lets you do is see the entire 3D picture of flow. So here you can see, well, my videos are not working well. It's kind of weird. Well, so what you'd see is these little vectors that go around the brain, and normally what we do for a phase contrast MRI is make one slice near the cranial vertebral junction in red, and that slice, there's a detail, important detail of the measurement, is that there's a physical thickness to the slice, and it takes the average signal across that slice. So you can imagine you're going to get velocities that are average across that big region. But look at this, you can see with your own eyes, I mean, things change really fast. The peak velocities are occurring very locally right here, right? So if you use a sequence, it just smatters it like a pancake and kind of loses a lot of the detail, right? Now what happens if you take the slice a little bit lower? Well, you might miss the entire peak velocities, right? And it's hard to compare pre-post surgery. How, you know, there's a lot of the details. The devil is in the details here, right? This is important stuff to quantify what's going on. So this CSF hydrodynamics can be assessed in multiple ways. One way we've also looked at this was doing something called longitudinal impedance. This is sort of resistance to CSF flow dynamics, doing a 3D model of the cranial vertebral junction. I don't have time to say all the details, but essentially what we saw that it is higher resistance in the Chiari malformation patients at the cranial vertebral junction than healthy volunteers. But there is some overlap. It's not a total, bivariate distribution. Okay, so in CSF hydrodynamics, I think the take-home point is that flow looks like it's altered in general in patients, but it really depends where you look and how you look at it. So we need to further develop those techniques as well, right? Okay, so the last piece of my talk here is tissue deformation. So as I mentioned earlier, I'm sorry the videos are not playing, I'm not sure why, but you can see that the brain pulses in this person with each heartbeat, and this can be quantified in terms of bulk motion. So this is just sort of rigid body motion, we say in engineering sense. You can also quantify it in terms of strain. Strain is stretching and compression of the tissue, right? Relative motion. So there's a really nice study done by Lynn Bilston's group recently where they did tissue motion tracking locations. So you could see on that last video that only played once, the tissue kind of pulses with each beat. You can use imaging techniques to back out how much feature points move. And they did that here. These are the different points in the brain that they looked at. And then they did this before and after surgery. And what you can see is in almost every single location, the motion decreased post-surgery. You see pre-surgery is light colored here, gray, and then dark colored is post-surgery. You can see it's decreasing in almost every case. So my group actually wanted to carry this forward more, and we wanted to look at the spinal cord motion. And so we selected ROIs in the upper cervical spinal cord, you can see here. And we did this in controls, preoperative patients, and postoperative patients. The first thing we saw was the motion was elevated in the spinal cord in the patients versus the controls, healthy people. And that motion did decrease post-surgery, but it wasn't back to the original level, right? So it didn't sort of restore completely normative degree of motion in all those cases. So another thing we've been working towards is quantifying the stretch and compression, as I mentioned. So one way we can do this with a standard type MRI, phase contrast MRI, So take a ROI on the upper spinal cord here in blue, and in the pons here in red. You can see the trace of the displacement. This is just how it's moving back and forth. You can take them and subtract them. So if they're moving the same amount, you subtract it, you get 0, right? They're the same. But if they're moving different amounts, you don't get 0. And if it's positive, that means it's being stretched. If it's negative, it's being compressed with each heartbeat. So look at what we found. We found in the patients, it was essentially compressed every time the heart beats. That's the distance between the pons and the upper spinal cord. And in the healthy controls, it was stretched. That's a very different kind of dynamic going on, although there was some overlap, right? It's not completely separate. Okay, so then we wanted to look at this in more detail. We found out in the cardiac MRI, there's something called dense MRI that is used to quantify displacement of tissue directly. The reason why we chose this is because it does it very in high detail. It's 10 micron displacement steps. So to give you an idea, a human hair is 150 microns. So very high precision displacement. So here is a scan that we did on a patient pre-surgery. We can actually encode the displacement in AP or superior inferior directions. Here's AP, superior inferior. You can see black represents bigger displacement. You can see displacement is occurring in AP and superior inferior direction. You can see near the tonsils, it's a huge amount of displacement. It's actually doing something we call aliasing. You get phase wrapping, and it's basically beyond even what the sequence can measure in terms of motion. Now look what happened post-surgery. All that displacement went way down. Here's a healthy control for comparison. So this has been done in more subjects, and we can tell you that the findings are promising on this sequence. And so I think the take-home point in the tissue deformation is that most studies indicate there's some role of tissue deformation in Chiari malformation. And really what we need to do there is there's multiple ways to look at displacement deformation. We want the simplest way. We don't want it to be more complicated than it needs to be. And so the title of my talk was Establishing Novel Neural Tissue Deformation Biomarker for Chiari Malformation. So we're very fortunate to receive a R01 grant. It's a kind of a federal grant that will help us look at this question. And it's with Johns Hopkins University with neurosurgeon Mark Luciano and collaborator John Ashinsky, Ari Blitz. It's a 5-year project. And we're going to be looking at deformation assessment in Chiari along with a bunch of other parameters I talked about in my talk. And I'm hoping, next year I'm going to have some more results. Gwen is going to be working on this. She's going to be working very, very hard on this. So we're very excited to get started. And I want to point out that we used a lot of preliminary data from projects that were previously funded by ASAP in that grant submission to the National Institute of Health. So we're really grateful for that. That's really important. You can't get these federal grants without having very strong preliminary data. So we're really grateful to ASAP for that support. So we are enrolling patients. So if you have your pen and paper here, we're trying to find people who have not had surgery. Oh, if you had surgery, we can't do that. We need patients who haven't had surgery, asymptomatic, quote, Chiari patients, or healthy controls, and ideally sort of age, sex matched. The study's near Baltimore, Maryland, so you need to get there. This is the contact email, brynm@uidaho.edu. Yeah, and we can tell you more about that if you're interested, so I'd be happy to talk with you about it. Okay, so I hope you see from my talk is at least, I've been looking at Chiari for at least 15 years, maybe 20 years approaching now. I feel the most optimistic I have about the tools that are being developed. There's a lot of publications, especially in the last 3 or 4 years on Chiari. It's kind of just jumping out. And we have a lot of tools. We're developing these tools. We really need to start thinking about how can we test these in a good multi-center study. I'm hoping that my R01 project will be a launching point to bring that forward further. And definitely the clinicians need to probably be leading this kind of thing, and we need to step aside because it's a multi-center clinical study, but we need to talk about this. So we need to use these diagnostics to essentially, at the end of the day, improve the patient care. Hopefully you saw that sort of the different ways we look at static and dynamic in different aspects. I want to acknowledge the many collaborators. These are just a few. Postdoc Ansani Urbizu, who worked with me for a while, John Ashinsky, Mark Luciano, John Tu, who collected some of the preliminary data for this work. Also my PhD advisor, Francis Sloth, who's been definitely the singular most important person to help me get going in Chiari and Syringomyelia. Also for the funding, and I'm open for questions.